Hello, welcome everyone to today's APMEN Tech Talk webinar. I'm Richard Maud, Head of the Epidemiology Department at Mahidol Oxford Tropical Medicine Research Unit and co-chair of the APMEN Surveillance and Response Working Group. We will begin today's Tech Talk with some opening remarks from my APMEN SRWG co-chair, Dr. Ratanase Petsavan, who is Director General of the Department of Communicable Disease Control, Ministry of Health in Lao PDR.
Good afternoon, distinguished speakers and colleagues. Thank you, Professor Richard Maud, and also to all of you for joining us today. We are very pleased to be able to welcome you to another Tech Talks webinars hosted by the Surveillance and Response Working Groups. As many of you know, the SRWG is a peer-led technical working group that is established to promote technical exchange between our 21 partners countries and over 50 partners institutions. Therefore, your interest and participation in our activities, such as this webinar, is vital to ensuring that our networks is engaging with the collegiate spirit of APMEN's working groups. Over the past month, the SRWG have been preparing for multiple upcoming activities. In the next few weeks, the coordination team will be preparing official invitations to the SRWG annual meetings, which will be hosted as a hybrid meeting in Bangkok from the 1st to 2nd December 2022. We highly encourage partners countries and partner institutions to join us for the first face-to-face annual meetings since 2018. I look forward to meeting many new colleagues and particularly with some old friends in Bangkok later this year. Starting from next week, the SRWG will also be hosting a series of online trainings on introductions to the management and use of geospatial data and technologies for national malaria control programs, which will be facilitated by one of our distinguished speakers today, like Dr. Steve Ebener, who leads the Health GeoLab groups at the Mahidol Oxford Tropical Medicine Research Unit, or MORU. The training targets surveillance, monitoring, or data information officers nominated from national malaria control programs to strengthen the technical skills and practice to manage and use geospatial data and technologies. I'm delighted to hear that the course will welcome 27 national malaria control programs participants from 15 countries. Our today's Tech Talks webinars will focus on the use of geospatial data and technologies to improve accessibility of health services. As we all know that for malaria, prompt assessment to effective diagnosis and treatments is central for achieving eliminations. Therefore, geospatial data and technologies are increasingly used to guide public health programs by analyzing how affected populations are easily accessible to health services, or how could malaria service locations be optimized, including the timely deployment of community health workers and allocation of long-lasting insecticide-treated nets. However, application for designing and targeting malaria interventions are still emerging, especially in our regions. Our distinguished speakers for today include Dr. Steve Ebener, who I have previously introduced, and Ise Pantanila, a GIS specialist, also in MORU Health GeoLab groups. Our third speaker is Dr. Peter Macharia, from the Population Health Unit at the Kenya Medical Research Unit under Wellcome Trust Research Program in Nairobi, Kenya, who will be presenting case example from his best practice from his work in accessibility analysis in Africa. Finally, my co-chair, Professor Richard Moth from Moru and host institutions of the SRWG will be facilitating an Q&A and discussion session in which we would like to hear from you about potential applications of this type of analysis for malaria in your countries, including in our regions. Great things will always happen when there is a gathering of great ideas or thinking. And therefore, it is with great anticipation that I declare the start of this webinar. I look forward to another engaging discussions from this collision forums. Thank you very much for all of your participation. Thank you. Over.
Thank you, Dr. Betzelan. So we will have two talks followed by about 15, 20 minutes for discussion and Q&A. So if we can ask you, please hold any questions until the end, but you can type in the chat as we go along. The audio and video for attendees will be disabled just because it's such a large group. So you'll have to type your questions in the Q&A box. For the panel discussion, we're particularly interested to hear from you about experiences in conducting accessibility analysis that you've come across, the main challenges encountered during these sorts of analyses, and then any support that might be needed by national malaria programs for conducting this analysis. So now over to our first talk by Dr. Steve Ebner and Ise Pantania from Moru, with a general introduction on the origin, components, approaches, data, and process. Steve.
Thanks, Richard. Sharing my screen. So thank you very much for the opportunity to present today about this topic that has been of particular interest on our side for now the past 2 decades. Starting my video, here we go. During this presentation, Ise and I will be covering a little bit of the origin of this kind of analysis, the components as well as the approaches that are being used to do that, the data as well as the process behind the use of geospatial data and technologies to improve accessibility of malaria services. Physical accessibility to healthcare services in the context of today's presentation refer to the possibility for a given target population to reach or to be reached by such service, and this within a given distance or travel time. This is why this measure is also often referred to as geographic accessibility. Measuring the part of the population that can geographically access a given service is an important indicator to understand the performance of the health system in general, as well as for specific programs, and at the same time, therefore, identify potential gaps in such performance. This kind of measure contributes to better planning of resources to answer communities' needs, which is directly having an impact on health outcome, and this independently from the program actually that you are considering. And this kind of measure is therefore ultimately an important component of the overall health system and of each health program, including malaria elimination. You might be familiar with what we call the Tanahashi framework, which was published back in 1978, and which is being regularly referred to in relation to universal health coverage. In this framework, Tanahashi was looking for a given intervention at the different factors that are leading to part of the target population to be lost at each stage of the service provision process. So as you go up in the process, you lose part of the population to have at the end the one that is effectively covered. And in this framework, the 3 layers that are of particular interest to us are the first 3 layers, which have a very strong geographic dimension. The first one is, of course, the spatial distribution of the target population, which is key to understand where the demand is located. And then you have the geographic location of the available services, which itself provides the spatial distribution of the offer. But having only these two elements doesn't allow to identify if the offer is located in the most appropriate places to cover the maximum part of the target population. And this is where accessibility coverage comes in to relate the spatial distribution of the population with the one of the services to identify if those services are within reasonable reach of the target population. So again, these three layers are really those of interest for the discussion today, even of course, if maps can also be used to understand the geographic distribution of the factors or the indicators that are related to the other layers in the framework. Now, the reason why we have been using geospatial data and technologies in general and geographic information system, so GIS-based approach in particular over the past decades for measuring physical accessibility to healthcare is of course linked to the strong geographic dimension of this first three layer in the Tanahashi framework. More specifically, if you really want to assess how physically accessible services are to the population, you need to be in the position to combine different data and information. In the Tanahashi framework, you already have the target population as well as the location of services. But in order to see how the patients are, potential patients or the population is moving from where they live to where they receive the services, you also need to consider the condition of the patient, depending on the illness that he is having, and also the type of transportation that he will be in the position to take, depending, for example, on his level of income to reach the services. And so this is something which is difficult to do in something like a spreadsheet. You need really to have access to specific tools like GIS-based approaches, which allows to take into account all of these, and not only when you look at physical accessibility to measure the percentage of the population that can reach a given service within a given travel time, but also looking at patient referrals, so between facilities, or when you look also at the delivery of services or commodities to the population or a given point of service or distribution. So these capabilities are at the origin of a growing number of publications on the topic, and this across public health programs. This being said, it's true that the number of articles that are dedicated to measuring geographic accessibility, specifically to malaria services, using geospatial data and technology could be higher. There's definitely an opportunity here, and we have the chance to have Peter today to take us through some of the existing literature a bit later. In the meantime, wanted us to look at some of the components that are key to obtaining the results from this kind of analysis, so in support of planning and decision making in relation to malaria elimination. The first one is, of course, the target population. And so if we use the malaria elimination continuum from the 2018 WHO reference manual as a starting point, we can see that this target population will evolve as the transmission decreases and reach also the point from where there is a need to maintain zero transmission in the country. So in order to be able to analyze physical accessibility to malaria services, the first thing which is needed is the most accurate possible spatial distribution of the target population that correspond to the phase in which the country could find itself towards malaria elimination. The next key element, of course, is in relation to the Tanahashi framework, is the availability and the location of the malaria-specific services. Here you have a matrix that Richard, with Peter's support, kindly put together to identify across 16 different types of malaria-related services, where these services are basically playing an important role across the different phases of the continuum, and also the anticipated direction of movement between the target population and the given service. So for some type of services, the population is generally expected to travel to the point of service, like the first one you have here. For others, the service is meant to travel to the population. And then in few cases, actually the direction of travel depends on the context. We'll come back to this a little bit later, but just to highlight already that there is a wide range of services along the continuum, and there is really a need, independently from the direction of travel, to have the master list of quality, so complete, up-to-date, without duplicates, etc., and accurate geographic coordinates for the service you are looking at in relation to the analysis and the measurement of physical accessibility. So Ise will come back to the question of data quality in a moment, but before that, I will let her talk about the type of indicators that can be obtained and mapped using GIS-based approaches. Ise, over to you.
Yes, thank you, Steve. So to continue, the indicators that have been mentioned can be grouped as follows. So the indicators aimed at measuring how physically accessible a given service or commodity is to the population, or could be accessible to the population if the current service delivery network was scaled up. Next is the one measuring how easily a patient can be referred to another health facility when needed. And last, those linked to the delivery of service or commodities outside of where they are based or stocked. So the lists that are presented here is not exhaustive, but this should already provide you with a good idea of the type of indicators that can be obtained and mapped through the implementation of the approaches presented today to support the planning and decision making. So most of the indicators that have been presented are measured against a specific type of geographic entity. And these entities can be of different types depending on the indicator being measured. So when it comes to physical accessibility indicators, these entities can be the administrative or health units, such as administrative or health districts, or they can be health areas that are defined for administrative planning or logistic purposes, or the proxy to these types of areas, and can be created using GIS-based approaches when the geographic extent of the real areas are unknown. Example of this are district level percentage of population reaching G6PD testing in less than 1 hour. Next, the geographic entities of analysis in the case of referral or service commodity delivery indicators. These are directly the warehouse or point of service or distribution. Example of these are percentage of vaccination points located further away than 1 hour from the health center they are attached to. And then it is also important to emphasize the different approaches that can be used to obtain the physical accessibility related indicators listed in the previous slide. So these different approaches are used to spatially connect the spatial distribution of the target population with the nearest point of service, the primary point of service with the referral health facility, or the infrastructure in which a commodity is stored and the location where it is meant to be used or distributed. So the approaches illustrated in the upper part of the slide are based on distance, while the lower ones are based on travel time, as you can see here. While some are more appropriate than others, all the 6 approaches illustrated here have been used to measure physical accessibility to healthcare. These are in terms of population coverage, depending on the context and the quality of the data being available at the time of conducting the analysis. And then when it comes to referral or delivery of commodities, the methods based on the road network are generally being used as these represent the fastest path when a motorized vehicle is being used. So unfortunately, we will not have the time to discuss the pros and cons of each of the approaches that was presented during this tech talk. But there are two specific points that we would like to emphasize here. The first one is it concerns the use of travel time versus distance to measure physical accessibility. So while distance continue to be used in countries because this measure is easier to implement, but time is a more adapted measure when it comes to accessibility. This is because it allows to consider important factors such as difference in transportation media, the patient condition, or climate. These are factors that might influence the decision of a person to reach for care. And this is one of the reasons why travel time is often associated with the need to receive emergency care. And in view of this, and as much as possible, time should be preferred over distance when measuring physical accessibility to healthcare services. And the second point is to emphasize here that the importance of the direction of travel. And this is when the environment being crossed is very heterogeneous, meaning there are important differences in altitude. And so the mode of transportation is influenced by this heterogeneity. And next, as we go on, as important, if not more important than the approach itself, this is the quality of the data which it will be applied. So the quality of the results obtained through which the approach will be only as good as the text which was used. So we have the concept of garbage in, garbage out. So this requires for the data being used by the geospatial data, especially the geospatial data, to present the highest quality possible across the 6 dimensions of data quality. This is completeness, uniqueness, timeliness, validity, accuracy, and consistency. So before we talk about the importance of the data quality, let's first look at the data that is needed to measure the accessibility depending on the approach being chosen. So geospatial data, this is the most important type of data here. So for those of you who are familiar, we are using both vector data and raster data formats. So in the examples, you can see here the boundaries of the geographic entities of analysis, the location of point of service, the road, the hydrographic network. These are all captured in vector data. While the digital elevation model, the land cover, and the population distribution, these are captured in raster format. So it is important to measure here that the other types of geospatial technologies also can be involved in the collection, extraction, or improvement of the data presented here. Namely, we have the GNS-enabled device. These are used to collect geographic coordinates like points of service or distribution, and also remote sensing that will be used to generate raster format data that can be used to extract location of point of service as well. And sometimes it can also be used to extract hydrographic or road network. And then for the other critical input that we need is travel scenario. This is being used to model the movement of the population going to the nearest point of service or being visited by the service provider, or the movement of the person bringing the commodities to the point of service or distribution. So different modes of transportation or combination of modes, this can be considered depending on the context or the anticipated condition of the population, or in each scenario extending more or less the reach of the population. And now let's dive into the geospatial data quality and the impact of low quality data, and that will have on measuring physical accessibility. So first we have the completeness. So if there are missing coordinates, like for example, missing, you can see here at the top, there are only 6, well, there should be 10. So it underestimates the accessibility. And then next year at the bottom, you can see if there is a problem with uniqueness, like you can see here, there are duplicates, then what will happen is there will be an overestimation of the accessibility because it is considering more points than there is in reality. So the two examples here emphasize the importance of having a master list of quality for all the points of service being considered. So next we will have the importance of temporal discrepancy. You can see here a combining road network back in 2005, and then we have the boundaries for 2010 and the location of the point of service for 2015. This will definitely not give measures of accessibility that are representative of 2022. And next is the accuracy. This is a degree to which the information being captured corresponds to reality. So when applied to geographic location, as you can see here, lack of accuracy will result in some of the points that will fall far from their actual location. Like here, you can see in the slide, one is in the top of the mountain, one is in the lake. So if these are not corrected, this will result in wrong or even no population accessing the point of services. Also, even small error in accuracy can sometimes lead to some points falling on the wrong side of the river, as you can see in the bottom right corner of the slide. And the last thing to mention here is that the satellite image, which is obtained through the use of remote sensing, is often being used as a ground reference to evaluate the accuracy of the geographic coordinates. So we have here regarding the validity, the data quality regarding validity. This refers to the compliance of the geospatial data being used against predefined benchmark, for example, in terms of projection. And while the consistency between data sets, it refers to the absence of apparent contradiction. You can see here in this example, there is a shift between two data sets. This will lead also to the wrong or no population accessing the service as per the analysis or generating results that are not realistic. So in conclusion, the highest quality should be sought for geospatial data being used to measure physical accessibility to healthcare using GIS-based approaches. So I will now give the floor back to Steve, who will talk about the process to be followed for the indicators. Steve?
Thanks, Ise. So what you have here is really the high-level description of the process that is to be followed to obtain one or several of the indicators we were discussing earlier and present them on maps. At this level, the process is very similar to the process you will apply for conducting other type of analysis using geospatial data and technology. So I'm not going to go too much in detail, but it starts by deciding the indicators of the maps, understanding what we call the accessibility context, which is going to be leading to the identification, of the most appropriate GIS-based approach and tool to obtain this indicator. Once this is the case, the data that is available is assessed for quality before trying to improve this quality, starting with the dimension that Ise just mentioned. And once this is done, implement the approach, obtain the indicators and all the maps and use them. So this looks like being quite straightforward as a process, but actually implementing these requires specific technical skills and expertise in the management and use of geospatial data and technologies. So as a start, I mean, you have here 3 resources, a specific training that was given in Vanuatu at the end of 2019, a specific tool also that has been developed by WHO and since back in 2005, the first version, with the different material pertaining to physical accessibility to healthcare. The last link itself gives access to more reference and training material related to the management and use of geospatial data and technologies in public health. Just to conclude quickly, geospatial data and technologies can be used to measure physical geographic accessibility to healthcare services, and as well as preparing the data for it to be conducting this analysis. There is a growing number of documented use cases, could be more of these use cases for malaria. There's really a potential to increase the number there. There's a need to have a very good understanding of the analytical context and the different approaches that can be used to measure these indicators and creating these maps. And in relation to that, data of quality also is key to really obtain measurements that will inform planning and decision making. Implementing the process requires some technical skills and expertise. And Dr. Atanasai mentioned earlier about the online training that APMEN is organizing, and Ise and I have the chance to facilitate in the coming weeks with a representative from NMPs of 15 countries. Let's now maybe enough for the theory, and let's have a look at some concrete malaria-related use case. Over to you, Peter.
Thank you, Stephen. Maybe just jump in and say if the audience has any questions, please put them in the Q&A box. It seems to be working now for everybody. So our third speaker is Pete Charrier from Kemri, who's going to talk about geographic access to healthcare in sub-Saharan Africa with some use cases for malaria. Pete.
Thank you. Let me just share my screen. Can you confirm that the slides are in presenter mode?
Yeah, thank you.
Thank you, Richard. Hi, everyone. I'm going to take over from where Steve has left. So using all those methods and data sets that they have described, I'm going to show examples that we've done in the past, including other authors, to bring all that together and compute some access measures, some related to malaria, some not related to malaria, but can be applied in the context of your case if you have a malaria example. And I'm going to start with this example where we wanted to estimate travel time to urban centers in Kenya. So this can be travel time to any other service point. This is just an example of urban centers in Kenya. So we wanted to identify, are there any marginalized populations that would require prioritization and targeting for the case of urban areas? And why this was important was because we know that in urban areas, most of the healthcare services, educational services, financial, trading services, employment, government services, or majority of them are available in the urban areas. So therefore, if you are nearer to those services, you are likely to have better outcomes, may it be financial or health or educational outcomes. And we know that all these are related to SDGs. So the more easier you can access those services, the better your case. So we wanted to estimate access in Kenya to these urban centers. And the first point was to gather data, as they have just explained. And as you can see on this two map, we have the urban areas in Kenya in 2019 from our census reports. Then we have a comprehensive road network here that was based on data from OpenStreetMap and from the national agencies in Kenya. Alongside that, we had land cover data. We had digital elevation model to correct for walking and bicycling speed. We also had water bodies and protected areas because these are barriers and you cannot walk across them. Then we had a graded population data set that we matched to our census data from WorldPop. Then we estimated travel time based on 7 models of transport that they are likely to be used in Kenya. So somebody could be walking, another one could be using a bicycle, somebody could be using a motorcycle, or a vehicle, or you could use a combination, and the combination could be maybe you walk, then use motorcycle, or you can walk, use a motorcycle, then use a vehicle. So we wanted to use all these modes of transport so that if the government wanted to intervene in an area, they could say, for example, if we introduced bicycles or reduced taxes on bicycle in this area, people could better access services that are in urban areas, for example, or any malaria-related services that you might have in mind in your context. Then we wanted also to aggregate all the measures that we get at subnational levels used for decision-making in Kenya, which are counties which came into 2013 after we had a new constitution. We also wanted to relate these travel time measures to sustainable development goals and to see how they relate and if they make sense based on our hypothesis that we had initially. So some very high level results here. So this is travel time to Kenya, to urban centers in Kenya based on the 7 modes of transport that we've used. So the first one is walking only, and the green areas is where the travel time is less than 30 minutes or it's shorter. Then the red areas is where travel time is high. And you can see as you get a better means of transport, you are moving from walking, say, to using a bicycle, to using a motorcycle, to using a vehicle, you have better access. And it even gets better in some cases when you use several combinations. So here, for example, if you wanted to increase access in some very rural areas and you introduce some motorcycles that can navigate in the terrains that are usually found in rural areas, people could maybe slightly better access those services. So what we found is that the access was very heterogeneous and it was associated with most of the SDG indicators, so confirming our initial hypothesis. And here we identified marginalized areas, and this gives some insights to what modes of transport can be used to improve services in some areas. And this translated to, in the malaria context, you could be estimating travel time to a service point. Say, for example, if people are to get bed nets from a health center, we have now malaria vaccines, and in some countries, they will be accessing these within the immunization services, and they have to walk or use a motorcycle or use a vehicle to go and access those vaccines. Also, you could be moving from headquarter to homestead, for example, if you're going for insecticide spraying services or other related services. So that's the first case study. The second case study looks at geographic coverage. So what is the proportion of population within some threshold that is recommended? And in this case, this is analysis that was in the entire of sub-Saharan Africa, led by my colleague, Paul. So we wanted to assess physical access to hospital care in sub-Saharan Africa and determine the population of women of childbearing within 2 hours, because for emergency and obstetric care, there is a policy threshold that has been recommended of 2 hours. Further, another policy states that at least 80% of their population should be within 2 hours. So we wanted to assess what is the proportion within these 2 hours and how many countries in sub-Saharan Africa have reached this threshold. Again, this can be translated directly to a malaria case if you have a policy threshold that has been set, for example, maybe 30 minutes or 1 hour, and you want to have a certain population being within this threshold. It goes to the basics that have been presented, the fundamentals. So you want first to assemble data. So this is the population distribution within sub-Saharan Africa from WorldPop. Then we assembled all the road network in sub-Saharan Africa, and this is based on OpenStreetMap and Google Maps. Then all the health facilities in sub-Saharan Africa that are hospitals specifically. So this was the first Pan-Africa geocoded database of public hospitals in 48 countries and islands. So, and we estimated the travel time in access mode as earlier explained. Some high-level results here. So this graph shows the proportion that are within 2 hours, and there is the cutoff of 80%. So you can see only about 16 countries are meeting this threshold of the population within 2 hours, and 28% of women of childbearing age were marginalized, so they were living beyond the 2 hours that is recommended. And if you want to see that graphically, is the map shown here. So 2 hours is the green color. Those people are within 2 hours. Then where you have an orange, that is where you have people living more than 2 hours and you have quite a substantial population there. Then the light colors, the light yellow is where you have people living more than 2 hours, but there isn't a lot of population in those areas. So if you wanted to target your population, you are very sure which areas you would want to target. So which country and which areas within that country that you would want to target. So this applies to malaria context in your country. It could be coverage of people under different malaria services within a defined threshold. So it could be a defined threshold within a subnational unit. It could be nationally, it could be regionally, and it could be different malaria services. That case study that I want to present is the use of modeled catchments to compute your denominators. So for example, you have a service point, which could be a health facility, and you want to determine the population that is being serviced in by that health facility. Could be a hospital or a health center or a health post, but you don't have that population directly available. So you could model a catchment around that facility and overlay with population distribution to get a population denominator for different applications that are related to malaria. And in this case, this was an example in Kenya, and we wanted to know the bed nests that are allocated to each health facility. Are they enough or they are not enough? So we modeled a catchment area, then estimated the number of pregnant women who would need a bed net in that catchment area and compared to what the government had provided. So the data sets that we assembled for that work first was to get the health facilities that are distributing the bed nets, the land cover of the area, the births and pregnancies expected in that region, the digital elevation model, and the road network. Then all these data sets were combined within access mode and mapping softwares in this framework here, but I'm just going to concentrate on the catchment area. So for the catchment area, we needed to model the travel time, which is the first thing here as explained, model travel time. Then you want to know what is the maximum distance that people are walking in that area using data from household surveys. So if you combine that two, you can delineate a health facility catchment area. And if you use the population of pregnant women in that region, you can estimate the number or the proportion who are likely to visit a health facility. This is using some spatial modeling techniques. And using this catchment and the proportion likely to attend a health facility, you can get the number of bed nets that should logically be allocated in that area. And this process was done in access mode, ArcMap, and R. So this is how the results look like. So this is the travel time within the region, and these are the model catchment areas. So if you see green somewhere, the allocation of bed nets in that area was okay, it's fine. But if you see where you have an orange, that is an underallocation, then a yellow is over allocation. Then the very red areas are areas which are very far away from a health facility, which were uncovered, which if you want to improve coverage of bed nets, you might think if you need mobile clinics in that area, or what means you want to use to distribute your bed nets, or any other commodity that is related to malaria. So for catchment, we can determine, we can use that to determine the denominator, and we can use that denominator to compare with different things, or maybe, for example, estimate the demand, for example, of a vaccine for children within a certain facility if we don't have alternative data directly available. The fourth case study, so we can use travel time to see what is the effect on outcomes. And this example here is from 2009, where they looked at the impact of travel time on malaria hospitalization within a region in coastal Kenya. So here they modeled travel time from where each child was living along a road network. And by that time, they were using C++ to estimate travel time. And when they related with malaria incidents, as you can see from this graph here, so as travel time is increasing, also incidence is increasing. So what they concluded is that the incidence of hospitalized malaria more than doubled as time to travel to the nearest primary care facility increased from 10 minutes to 2 hours. So you can use these measures of travel time to see what effect they have on different malaria outcomes within your region. So for example, people getting vaccines, those that are very far away, are you having spraying or another outcome for those people who are very far away from the central point? And they also concluded that if you have good access to primary healthcare facility, you might reduce the disease burden by as much as 66%. The last case study that I'm going to show here is an optimization case. So for example, you want to understand what is the effect of increasing service point for a certain health outcome. So this is Rwanda, and they are showing access to cancer facilities. So there are 2 at the moment, and this is how access looks like if you use access mode and all the data sets that were described to measure travel time to these 2 cancer facilities. What if you increase the 2 to 7 within different areas where access was poor? What would change? So this is just an example of an optimization case. And they are showing here in these 2 graphs that people who are within 1 hour, so the recommended threshold, would increase from this low percentage here of about 30 to a very high percentage of 70. So you can have different optimization case. So this is just an example. What would happen if I increase my service point for a certain outcome? And they further looked at how does this affect poverty if we do the increase in the service point from 2 to 7. How does it affect the region balance? How does it affect access in urbanization? So you might have different services here, different scenarios. This is just to show you that one can do this analysis of optimization within a geospatial framework. So to summarize here, you can compute access to different malaria services that apply to your context. You can also see the population that is covered within a certain policy relevant threshold of, say, 1 hour, 15 minutes, 2 hours, based on your context for any malaria service that you might work in your case. You might also model catchment areas to compute population denominators if these are not readily available. And you can relate travel time to different malaria outcomes to see what is the impact and what would be the benefit of reducing travel time to a certain malaria outcome. You can also do optimization based on population coverage, travel time, and different referral patterns. Thank you. That's the end of my talk, and I'll take it back to Richard.
Thank you very much, Pete. Fantastic talk. So we're going to use the remaining time for some Q&A and a bit of discussion. And it's been a very active Q&A and chat. If you've got questions, please put them in the question and answer box, and we'll try and get to as many as we can. So I've been taking notes. There's a clear theme coming out from the questions for Steve. Maybe Steve, can you put the camera on? He's here as well. So Steve, there's been a couple of questions about using GIS for mobile and migrant populations. So with the example of in Cambodia, malaria is, it says, coming from forested areas where the population is dynamic. So that's seasonal workers and mine workers. And how might GIS be useful?
Thanks, Richard. Well, you're actually a much bigger expert on that question than I am. And definitely there's a lot of work that is being done in relation to population movement, modeling these movements. I think definitely that could be an interesting topic for another tech talk. Thanks.
Yeah, maybe particularly for accessibility, the analysis that's just being presented. So there's also a question, you've answered a couple in the chat, but maybe we can talk a bit more about how to collect the data on travel mode speed. That came up during Pete's talk, but you put a response in the chat, Steve.
Yeah, no, I can maybe expand a bit on this. This is a very important factor, and also currently a topic for a lot of discussion, especially when it comes to how fast do people walk in the reality compared to this norm that has been used for several decades now, which is basically 5 kilometers per hour. And with more and more discovering that this doesn't apply for a large part of the population. So in terms of the methods to identify these, of course, the more informant type exercise, workshop, or surveys you can have locally, the better, to be as close as possible to not only the reality of the mode of transportation that the population is using, but also on the speed that these mode of transportation could reach, depending also often on the state of the transportation network, right? The quality of the transportation network itself. So I think what is really important here to remember is that all these methods are models, right? I mean, we are looking at these from the perspective of a kind of an homogeneous, of an ideal scenario of the population moving to the nearest point of service or being served by a certain type of staff. This is one aspect where these analyses become very powerful, is when you can complement them with something like patient exit surveys, where you identify exactly where the people are coming from in the reality, and by crossing the two types of results, you identify some specific areas where people should have come from, but they actually did not come from. And that's where you can come and go with another type of tools, like a household survey, to try to identify why this population in those areas actually did not go to look for service. So all what is presented today is one aspect, and it's very useful. The example from Peter are showing this. It becomes even more powerful when this can be cross-referenced with other source of data. Thank you.
Great, thanks, Steve. A question for Pete. So in the study that assessed the association between travel time and hospitalization for malaria, were there any hypotheses for the causal factors for this relationship?
So I would think normally what people would hypothesize is that if you are very far away, you are unlikely to be attending to a facility, so you get sick and you don't go to a facility. I would think that is the rationale that they put behind, but the link to the talk is also shared for that specific paper for further details on it.
Great, thank you. And for Ise, there's a couple of comments about where there's no road network. So someone just posted a comment about boat travel, for example, in Bangladesh would be relevant, and what to do if there's no established road network. So Steve's put a little bit of a response, but just wondered if you could comment about that sort of situation.
Yes, because travel can also happen not just on road networks, but also on what we usually call as land cover. So people also travel on those areas, bare areas, vegetation cover. So in those cases, for those models, in the travel scenario, there are also certain speeds that are allotted for this land cover classification for people to be able to, for us to be able to measure how accessible an area is if there are no road networks in those particular area. And just to mention, because I also saw the question about the boat travel being used in Bangladesh. I remember one of the study that we did that indeed boat travel is extensively used in Bangladesh. That we had to add the boat routes in the transportation network that we have for the country. Yeah.
Right, thank you.
Over to you.
Maybe I go back to Pete for the next one. So there's a question about availability of RDTs in the community, and if that reduces the time to access care, potentially averting mortality and death, why don't they provide such facilities in areas, which I imagine being remote areas? So I guess the question is about, can you use accessibility analysis to decide where to put this sort of service?
I think so, and I think Kenya is a good example, because in Western Kenya, we have community health workers who have RDTs that they can use in the community. So these essentially will reduce the travel time that a person will take from residence to go to the facility. But there would be also issues whether community health workers should be having these RDT, whether they are trained or not. So that is a different conversation altogether. But using the travel time metrics, maybe to help facilities that have RDT, would show areas that are marginalized and appropriate interventions that might be used in those areas. What we've just discussed being one example, and probably others might be implemented by the subnational government of that area, probably.
Great, thank you. So I'm going to go back to Isa for the next one. And Isa, you've got quite a lot of experience organizing the data and doing this sort of analysis together with Steve. Can you comment on some of the biggest issues that you've faced when trying to prepare the data needed for this?
Oh, yeah. So I would say that one of the biggest issues that we have encountered is the lack of the master list for certain geographic objects, such as in this case, maybe the points of service. And by this lack, it hampers for us to effectively assess the quality of the geospatial data. And another issue that I would say is when we have collected the data, we can see the quality. And there are issues there, starting with the inaccurate geographic coordinates or maybe incomplete road network. And this would need to be maybe recollected or modified in order to complete.
Right, yeah. There's also the challenge of whether the service is actually available at that facility, even if it's in the right place on the map.
Yes, yes, indeed.
So, Steve, a question for you. There's a question about some examples of where this has been used, but then some examples of public health programs beyond what Pete's already mentioned, maybe for the audience to hear about.
So other type of programs, right?
Yeah.
Well, actually the interesting part of looking at physical accessibility, and one of the reasons why we started working in this area, is that this is actually applicable to any type of programs, right? You will always have a question of accessibility to care or accessibility from the service to the population. So it's applicable across the board. Personally, we have been looking at accessibility analysis in relation also to primary health care, universal health coverage, right? In addition to that, emergency obstetric care. Actually, the starting point of access mode was in relation to this. Emergency management in general, that's maybe something which we don't see much yet, but as part of vulnerability and risk analysis, we are looking at how the first line responder can reach, how fast can the first line responder reach the areas that could be affected by a natural hazard, for example, and then this population reaching the nearest point of service where there will be emergency services. And then the growing field is definitely immunization. But interestingly, it's not only in terms of accessibility, but it's also in terms of ensuring that the whole surface of a country is attributed to a given point of service. So basically not missing any settlement in a given country. And therefore, we use these methods to delimitate area which are travel time based and make sense, where the people are most likely to go and direct themselves to reach those services. Over.
Great, thank you. So we've got a couple of minutes left. There's going to be an evaluation form pop on people's screens just to get feedback. I can invite participants, if you're interested to find out more, please feel free to reach out either through APMEN or directly to the speakers. We've posted quite a few links in the chat to further resources and information. And we are also, as you mentioned, we're organizing training for national malaria programs on GIS, but there'll be other training organized in future. Great. So the pop-up is open now. Please feel free to put in what you think, and we'll be planning future tech talks on other topics. So very open to any suggestions what those topics should be. So I'd like to close with just say thank you to everybody for joining the webinar. Thank you very much for your participation, and we look forward to seeing you all again very soon.
Thank you.
Thank you.
Thank
everyone.
you. Thank you. Bye.
Bye. Thank you.
Thank you.